Hi everyone, today I'll be presenting our Methotrexate Chemotherapy drug. Basically, Methotrexate Chemotherapy drug is a folate analog to treat cancer, autoimmune disease, ectopic pregnancies in cancer therapy. It's mainly used for leukemia, breast cancer, and osteosarcoma. Now moving to mechanism of action. First, methotrexate enter the cell. It then inhibit the enzyme dihydrofolate reductase. This inhibition block the conversion to dihydrofolate into the dihydrofolate. Since the dihydrofolate is essential for synthesis of purines or thymidylate, DNA and RNA synthesis is blocked. As a result, DNA and RNA and protein synthesis stop. Ultimately, it leads to inhibition of cell division, especially in rapidly dividing the cancer cell. I'm passing on my next partner.
Let's have a look at the pharmacokinetic properties of methotrexate. It can be administered orally or by subcutaneous injection. The dosage has to be increased gradually, and 20 to 30 milligrams per week is the maximum that can be given. MTX is absorbed in the proximal jejunum by PCFT, but sometimes enteric bacteria can convert it into 4-amino-4-deoxy-N10-methacteric acid. Most of the drug is distributed by being bound to albumin, but sometimes synovial fluid can also distribute it. The cells uptake methotrexate by using RFC1, where it competes against reduced folates for active transport. At higher concentrations, passive diffusion is also possible. MTX is metabolized to 7-OH-MTX in the liver. Inside the cells, they are polyglutamated to active MTX polyglutamate, which is retained in cells. Due to this, weekly administration is enough, even though generally the drug has a very short half-life. MTX is eliminated from the body intact after being filtered in the kidneys. Some of it undergoes enterohepatic recycling and biliary excretion too. This case is about a 35-year-old woman that presented to the ER with severe mucosal and skin lesions. She had mistakenly taken MTX every day for 12 days instead of the weekly prescribed dosage. Upon further observation, she had a severely low erythrocyte, leukocyte, and platelet count, along with critically impaired renal and hepatic function. After 14 days of intense treatment and monitoring, she made a full recovery.
There are three basic treatment regimens in correct use. 1. Conventional low dosage without citrulline factor. 2. High dosage methotrexate with citrulline factor. And 3. Intrathecal methotrexate therapy. The high-dose regimens with citrulline factor rescue can be further subdivided into those in which the antiflotate is administered by bolus or over 4 to 6 hours, and those in which methotrexate is infused over a 20 to 42 hours period. The former regimens result in peak methotrexate plasma levels of 10 to the negative 2 to 10 to the negative 4 m with an exponential disease reference. The infusion regimens result in fairly constant plasma levels during the infusion, with plasma concentrations ranging between 10 to the negative 3 and 10 to the negative 4 m depending on the infusion dosage. The rationale for the former approach is based upon the possibility that in poorly perfused or transport-resident tumors, cytotoxic intracellular drug concentrations can be maximized without intolerable host toxicity. The rationale of the infusion regimen is to encompass more of the cell cycle of the neoplastic cells to delay the citrulline rescue and to reach an equilibrium between plasma concentrations and the levels of drugs in interstitial and intracellular compartments. Which of these two types of regimens has the more favorable index is not known. 1. The drug of choice for intrathecal chemotherapy of cholangiocarcinoma and malignancies. 2. It is one of the two most effective drugs for maintaining remission in acute lymphoblastic leukemia. 3. At high doses, it has been shown to be effective against a variety of solid tumors, particularly osteogenic sarcoma, epithelial carcinoma of the head and neck, and lung cancer. 4. It is also considered the drug of choice for the treatment of psoriasis. 5. It is effective in the treatment of dermatomyositis, rheumatoid arthritis, venous granulomatosis, and sarcoidosis.
Now we talk about the toxicology. In our life, we know many people who have undergone chemotherapy and their body have more or less observed external damage. So, is MTX good or bad? First, let's discuss the relationship between mechanism of action and the toxicity. As an inhibitor of DHFR, MTX can inhibit the synthesis of nucleic acid, that is, which includes DNA, RNA, and protein. Since nuclear cell acid synthesis is the basic of cell proliferation, MTX is highly cytotoxic to rapidly dividing cell. But the problem is that although MTX mainly targets cancer cells, it cannot completely distinguish rapidly dividing normal cells such as bone marrow cells and so on. So damage to this normal tissue is the main source of MTX toxicity. So I called it double-edged sword. Next, let's talk about the main target organ toxicity and clinical manifestations. The first and most important and common one is bone marrow suppression. Bone marrow is the place where hematopoietic cells divided rapidly. MTX inhibits its DNA synthesis, resulting in the blockage of bone marrow cell proliferation. Clinical manifestations include leukopenia, which increase the risk of infection. Thrombocytopenia increase the bleeding risk, and erythropenia leading to anemia. The characteristic is that it usually reaches the lowest point 7 to 10 days after taking the drug. Hepatotoxicity. We all know that liver metabolism toxins. In this case, it's related to the metabolism of the MTX, the accumulation in the liver, and the oxidative stress. The manifestations are divided into acute and chronic. Acute is increase of liver enzymes, which is usually reversible. Chronic is the long-term use of low doses, especially in autoimmune disease, which may lead to liver fibrosis or even cirrhosis, which is more serious complication. Renal toxicity is that MTX is mainly excreted through the kidneys. High concentrations of MTX or its metabolites have low stability in the renal tubes and may form catalyst and precipitate, leading to renal tubular damage and even acute renal failure. It can cause dehydration, acidic urine, and renal insufficiency. Furthermore, high-dose MTX is especially vigilant about renal toxicity because kidney damage can lead to obstructed MTX excretion, which in turn increases systemic toxicity, forming a vicious cycle.
Toxicology management and prevention. Reducing risk. To reduce toxicity, doctors give leucovorin, which protects healthy cells from methotrexate's harmful effects. Hydration and sodium bicarbonate are used to protect the kidneys by helping the body clear the drugs faster. Doing regular blood tests, including food blood count, liver, and kidney functions, are done to detect any early sign of toxicity. And adjusting the dose in patients with a kidney or liver problems. It's also important to avoid certain drugs such as NSAIDs, penicillin, and some antibiotics because they can interfere with the methotrexate's clearance and raise toxicity risk. Moving to the improved efficacy. To improve treatment effectiveness, leucovorin must be given at the correct time. If it is given too early, it blocks methotrexate's action. If it is given too late, the risk of side effects increases. Blood tests help to track methotrexate's level. Doctors use this to decide when rescue treatment is needed. And next, the dose should match the patient's condition, including the kidney function, body weight, and genetic factors, since each body responds differently. Following the exact schedule is also critical. Delays or skipped doses can reduce treatment's effectiveness. To summarize, methotrexate is a chemotherapy drug that blocks DNA synthesis to stop cancer cells growth. It's used to treat many types of cancers but can cause serious side effects. Supportive care like leucovorin, hydration, and regular blood tests helps to manage risks. Proper timing and dosing are important to keep treatment both safe and effective. That's all.